Welcome back to the deep dive. Today, we are really getting into the weeds on a significant topic, hyperbaric oxygen therapy. We'll be doing a critical, unabridged synthesis based on a definitive integrated review. And for you, our specialist clinician listener, we know your baseline knowledge is already high. You're focused on the mechanisms, the protocol justifications, the nuances. So our mission today is simple, a high fidelity deep dive. We want to make sure every quantitative detail, every cellular mechanism from this complex source material is extracted, maybe even challenged a bit, and definitely organized for maximum retention and ultimately clinical utility.
Absolutely. And that mission really demands a clear structure today. We have to move systematically, I think, from the foundational physics right through to advanced clinical applications. So we'll start by establishing the historical context and, crucially, the fundamental oxygen physiology. Specifically, how does high pressure mathematically and physically re-engineer oxygen transport? That's key. From there, we'll shift into a really meticulous dissection of the 6 core cellular and biochemical mechanisms that actually drive the therapeutic benefits. After that, we'll analyze the detailed clinical indications, looking closely at the demanding protocols required for conditions like, say, refractory osteomyelitis or carbon monoxide poisoning. And we'll wrap up with a rigorous discussion covering crucial contraindications, the specific mechanics of things like barotrauma, and also the emerging science of hyperbaric oxygen preconditioning.
Okay, excellent. Let's start right at the beginning then. Define our subject with precision. What exactly is hyperbaric oxygen therapy?
Right. Simply put, hyperbaric oxygen therapy is the inhalation of 100% pure oxygen. But critically, it's done at pressures significantly greater than normal atmospheric pressure. We're typically talking within the range of 1.5 to 3.0 times the atmospheric pressure you'd experience at sea level. And this all has to happen inside a specially designed pressurized chamber, one built to safely handle those pressure differences. So, it's not just about breathing high concentrations of oxygen. The absolute crucial variable here is that increased pressure, the baric part of hyperbaric.
Got it. Pressure is key. Now, while the mechanics feel very modern, the review points out something interesting. The idea of using pressure modification for therapy actually has a surprisingly long history, doesn't it?
It really does. It's not some 21st century invention, even though its widespread use is more recent. It's more like an evolving application of some pretty established physics.
So who are the pioneers here?
Well, it's worth anchoring the timeline, even if our audience has some familiarity. The very first documented attempt to use pressure for health seems to date way back to 1662. A fellow named Nathaniel Henshaw, who was a British clergyman and physician, he built this sealed, airtight chamber he called a domicilium. Apparently, he used organ bellows and special valves to actually change the ambient pressure around the patient. Quite ingenious for the time, really, predating a lot of basic biological understanding.
1662. Wow. And even earlier attempts.
Yeah, even before Henshaw, back in 1620, Cornelius Drebbel developed a 1-atmosphere diving bell. So people were already engineering ways to deal with pressure dynamics very early on.
But it took quite a while to get from just manipulating pressure to using it as a targeted medical treatment.
Centuries, really. The first properly documented medical application we know of was in 1937. That's attributed to Bank and Shaw. They used a hyperbaric chamber specifically to treat patients suffering from decompression sickness. But the widespread adoption, the use of hyperbaric oxygen therapy for a whole range of conditions, that really only solidified after 1955. So its broad clinical use is relatively modern, even with that ancient theoretical underpinning.
Okay, history established. Let's shift now to the core science. This is, I think, what our specialist listeners really want to unpack. How does applying pressure fundamentally, mathematically, change oxygen delivery?
Right. We have to start with the baseline. Normal oxygen transport. Under standard atmospheric pressure, the vast majority of oxygen transport, around 97%, is handled by hemoglobin. It's the capacity-limited carrier. Now, contrast that with the plasma. Normally, plasma carries only a tiny fraction, about 0.32% of dissolved oxygen. So the normal total oxygen concentration in arterial blood at sea level is roughly 3 milliliters per liter. And here's the crucial comparison. The tissues of a resting, healthy person need about 60 milliliters of oxygen per liter of blood flow just for their basic cell metabolism.
Okay, so normally getting oxygen into the tissue depends almost entirely on that oxygen gradient driven by hemoglobin saturation, right? Where does hyperbaric oxygen therapy disrupt that?
This is where the physics of solubility becomes absolutely critical. It comes down to Henry's law. Henry's law states that the amount of gas that dissolves in a liquid is directly proportional to the partial pressure of that gas above the liquid. So under the high pressure achieved during hyperbaric oxygen therapy, let's say specifically, at an atmospheric pressure of 304 kilopascals, which is 3 atmospheres absolutely, the concentration of oxygen that dissolves directly into the plasma increases dramatically, exponentially even.
And there's a specific quantitative measure here that really highlights the impact, isn't there?
There is. At that pressure, 304 kilopascals, the plasma's capacity for dissolved oxygen shoots up to approach 60 milliliters per liter.
Wait a minute, 60 milliliters per liter? That's the exact same number you just gave for the basal tissue requirement.
Precisely. 60 milliliters per liter. At that point, the concentration of dissolved oxygen in the plasma alone is enough to meet the total oxygen needs of resting tissues. It means essentially you don't need hemoglobin for basic oxygen delivery under those conditions. Hyperbaric oxygen therapy temporarily makes the red blood cell functionally redundant for meeting those basal metabolic needs just by supersaturating the plasma. That's the absolute physiological foundation of this whole therapy.
So you're shifting from relying on a carrier with limited capacity hemoglobin to a system that's purely governed by pressure driving oxygen into solution.
Exactly. It's mass transfer driven purely by pressure. And there's more. During a standard hyperbaric oxygen therapy procedure, the oxygen partial pressure in the arterial blood can just skyrocket up to 2,000 millimeters of mercury, which is about 266.6 kilopascals. This huge rise creates a massive oxygen pressure gradient between the blood and the tissues. And this gradient, in turn, pushes the tissue oxygen partial pressure way up, potentially to around 500 millimeters of mercury, or 66.7 kilopascals.
Let's visualize that. If normal tissue partial pressure of oxygen is, say, 40 millimeters of mercury, pushing it to 500, that massively shortens the distance oxygen needs to diffuse. It ensures oxygen gets to even the most ischemic cells, right? Even if the capillary network is damaged.
That's exactly it. You're overcoming the diffusion barrier that the pathology created. You're bypassing blocked or damaged microvasculature simply because of the sheer volume and pressure of the dissolved oxygen. That steep partial pressure of oxygen gradient is really the engine driving the therapeutic effect.
And procedurally, what are we looking at?
Well, the duration varies quite a bit. It can be as short as 3 minutes or go up to 2 hours. It's always meticulously adjusted based on the specific condition being treated and the therapeutic goal.
It's also worth noting patients often experience some mild transient side effects. Things like a bit of discomfort, maybe some ear pain, especially as the pressure is changing inside the chamber. That's the common barotrauma we'll discuss in more detail later.
Okay, let's do a quick sectional micro recap here. The absolute key takeaway isn't the history, fascinating as it is, but the solubility physics. The primary mechanism of hyperbaric oxygen therapy is using Henry's law to supersaturate the blood plasma with oxygen. This delivers enough oxygen to meet basal metabolic needs without relying on the hemoglobin saturation curve. It overcomes diffusion barriers and dramatically raises tissue partial pressure of oxygen levels, potentially over 500 millimeters of mercury.
Okay, we've got the big picture physiological shift, supersaturated plasma bypassing hemoglobin. Now let's drill down. How does this high-pressure oxygen environment actually change things at the cellular and molecular level to achieve healing or fight infection?
Right, we need to start with the basics of cell energy. Mitochondria are the powerhouses, right? They use about 80% of our cellular oxygen as the final electron acceptor in the electron transport chain. That's absolutely necessary for producing adenosine triphosphate, or ATP, our energy currency. Now, when you have hypoxia low oxygen, this whole process stalls. And that leads to a really dangerous increase in oxidative stress. You get toxic free radicals of oxygen and nitrogen being generated, which causes cellular damage, death, apoptosis.
So the most immediate effect of hyperbaric oxygen therapy is simply correcting that lack of the final electron acceptor. But the review outlined 6 core mechanisms, and they seem to go much further than just basic reoxygenation. Let's unpack those.
Let's do it. Mechanism 1, antimicrobial and immunologic activity. This works in a couple of ways. First, the direct increase in oxygen content creates high levels of oxygen radicals. These are directly toxic to obligate anaerobic bacteria. Think of species like Clostridia, the ones that cause gas gangrene. Furthermore, hyperbaric oxygen therapy actually suppresses the production of that really nasty Clostridial alpha toxin. And it also seems to suppress virulence factors in Pseudomonas species, too.
So that's the direct hit on the bugs. What about boosting our own defenses?
That's the other critical part. On the host immunity side, Hyperbaric oxygen therapy helps restore the ability of neutrophils' key immune cells to kill bacteria. Hypoxia severely impairs neutrophil function, but flooding the area with oxygen restores their function. It stimulates bacterial lysis by leukocytes, basically giving our innate immunity a significant boost against both anaerobic and aerobic pathogens.
That's a powerful combination. Okay, mechanism 2, tissue repair.
Yes, the second mechanism is angiogenesis and healing promotion. Hyperbaric oxygen therapy is a potent stimulus for neovascularization, the growth of new blood vessels, especially in chronically ischemic or damaged tissues. This really speeds up wound healing. This effect seems strongly linked to an increase in vascular endothelial growth factor, VEGF. Yeah. Paradoxically, this hyperoxic environment triggers a signaling cascade that promotes fibroblast function, enhances collagen synthesis and proliferation, creating new vessels and the scaffolding, the extracellular matrix that's fundamental for healing chronic wounds.
This brings us to a really interesting point, maybe a paradox for some. Mechanism 3, anti-inflammatory and oxidative stress reduction. How can flooding tissues with 100% oxygen at high pressure, which sounds inherently pro-oxidative, actually reduce chronic oxidative stress?
Yeah, that's where the nuance really lies. Hyperbaric oxygen therapy creates a transient state of hyperoxia. Think of it as a powerful signaling event. While it does generate an initial controlled burst of oxidation, the body responds by significantly upregulating its own protective antioxidant systems, much more effectively than it would under chronic hypoxia. So hyperbaric oxygen therapy actually reduces chronic oxidative damage. It does this by preventing the widespread, uncontrolled release of those toxic free radicals and proteases that you see in chronic inflammation, and particularly in reperfusion injury. It also plays a key role in reducing leukocyte adhesion during reperfusion injury, lessening the damage when blood flow suddenly returns to an ischemic area. So that short controlled hyperoxic signal basically resets the cellular defense systems in a beneficial way.
Fascinating. So it uses the signal of high oxygen to trigger a long-term defense against the damage caused by chronic low oxygen. Okay, moving on. Mechanism 4 sounds counterintuitive, vasoconstriction.
It does, doesn't it? The fourth mechanism is indeed vasoconstriction. Hyperbaric oxygen therapy induces systemic vasoconstriction. Now, normally, that would be terrible for ischemic tissue. However, because the plasma is so supersaturated with oxygen, the reduced blood flow, which actually helps decrease inflammation and edema, doesn't compromise tissue oxygenation. The incredibly high concentration of dissolved oxygen in the plasma maintains or even increases the tissue partial pressure of oxygen despite the reduced flow. So you get the benefit of less swelling and inflammation without the cost of worsening hypoxia.
Clever. Okay, mechanism 5 takes us back to chronic cell responses.
That's hypoxia factor attenuation. Hyperbaric oxygen therapy works by lessening the harmful effects mediated by the hypoxia-inducible factor, or HIF-1 alpha. HIF-1 alpha is central to the body's chronic and often maladaptive response to low oxygen. By rapidly correcting the hypoxia, hyperbaric oxygen therapy limits those signaling pathways that tend to perpetuate chronic inflammation and tissue destruction.
And finally, mechanism 6. This one's key for certain emergencies.
Right. The sixth core mechanism is specific toxin dissociation. This is primarily aimed at carbon monoxide. Hyperbaric oxygen works incredibly well by rapidly forcing carbon monoxide off its binding sites. Most importantly, it kicks it off cytochrome C oxidase within the mitochondria. By freeing up that absolutely essential enzyme, it quickly restores electron transport and reverses the profound cellular energy crisis caused by carbon monoxide binding.
And just to reiterate, these powerful therapeutic effects are consistently achieved within that specific therapeutic window, 1.5 to 3.0 atmospheres absolute pressure. That range is carefully chosen to maximize oxygen solubility without tipping over into severe toxicity.
Exactly. And before we move on, let's reinforce one of those connections. Spaced repetition cue. Remember the specific growth factor we linked to mechanism 2, angiogenesis and healing promotion. That was vascular endothelial growth factor, VEGF. Hyperbaric oxygen therapy elevates VEGF, promoting new vessel formation, boosting fibroblast function, and helping with collagen synthesis, vital for repair.
Okay, let's try and apply that, especially the dual action of fighting infection and promoting repair.
Sure. Let's frame it as a board-style question. Imagine a patient presenting with chronic refractory osteomyelitis of the tibia. They're admitted for planned surgical debridement, followed by hyperbaric oxygen therapy. Now, considering the unique pathology of this chronic bone infection, which specific combination of cellular mechanisms is primarily responsible for ensuring a successful outcome? Pause.
I can see how answer choices might try to isolate just the anti-anaerobic effect or maybe just the anti-inflammatory aspect.
Right, but the required rationale needs that synthesis. The correct thinking has to involve the dual action. First, you need the stimulation of bacterial lysis by leukocytes and the direct suppression of anaerobic growth to control the infection. But that has to be coupled with the second part, the promotion of osteogenesis, bone formation, neovascularization, and collagen production, driven by things like VEGF, for the structural long-term repair of that compromised bone. Hyperbaric oxygen therapy is chosen for these tough cases, precisely because it tackles both the infection and the structural deficit simultaneously.
That synergy structural repair plus anti-infective action really sets the stage nicely for the clinical applications. The review gives quite an extensive list of indications, doesn't it? Covering infections, trauma, vascular issues, even radiation injury. Let's dive into some specifics, the protocols, and the reasoning behind them.
Makes sense. And we should probably prioritize the acute life-saving uses first.
Good point. Let's start with acompromess, necrotizing soft tissue infections. Thinking specifically about things like clostridial myonecrosis, gas gangrene, and necrotizing fasciitis.
Okay, the absolute key message here has to be crystal clear. Hyperbaric oxygen therapy is adjuvant. It's an add-on to immediate aggressive surgical debridement. That comes first, always. Its role physiologically is critical, though. That massive tissue partial pressure of oxygen we discussed is directly toxic to the anaerobes causing the infection. Plus, it enhances blood perfusion locally and helps restore innate immunity. But the crucial clinical outcome, the reason we use it, is that it often significantly reduces how much tissue needs to be surgically removed, whether that's amputation or debridement. It helps the surgeon clearly see the line, the border, between dead, infected tissue and the healthy tissue that can be saved.
Okay, adjuvant therapy helps demarcate tissue. Now, what about B refractory osteomyelitis? This sounds like a much longer-term commitment.
It definitely is. Hyperbaric oxygen therapy here is really reserved for those tough cases where standard treatments, extensive irrigation, debridement, long courses of intravenous antibiotics have already failed. As we established, it provides that necessary structural support. It promotes bone formation, new blood vessel growth, collagen production, all in bone tissue where oxygenation and blood supply are severely compromised. And the protocol detail really reflects that challenge of rebuilding bone. Typically, the therapy is delivered at 2.4 to 2.5 atmospheres absolute pressure. Treatments are frequent, maybe 5 to 7 times per week, and achieving clinical results, seeing reduced swelling, less pain after the surgery, requires a serious commitment. We're talking a total of 30 to 40 individual treatment sessions. It's a long haul because rebuilding compromised bone just takes time.
30 to 40 sessions. That immediately brings up questions about feasibility, patient compliance, and cost effectiveness, especially compared to just continuing antibiotics. How does the review justify that level of resource use?
The justification usually hinges on the success rate in salvaging limbs that might otherwise require amputation. In those refractory cases, standard care has failed. The lengthy protocol is necessary because bone and soft tissue regeneration cycles are slow, taking weeks or even months. Short protocols just don't provide that sustained hyperoxic stimulus needed to really drive the tissue remodeling processes like the VEGF-driven angiogenesis. It needs that prolonged signal.
Makes sense. Okay, let's shift to an acute emergency. See carbon monoxide poisoning here. Time is absolutely critical.
Absolutely. And understanding the pathophysiology deep dive is essential to grasp why hyperbaric oxygen therapy is so much better than just giving regular oxygen. First, carbon monoxide binds to hemoglobin incredibly tightly, about 200 times more strongly than oxygen. That obviously reduces the blood's oxygen carrying capacity. That's problem number one. Problem number two, which is arguably more insidious, is the left shift. The hemoglobin sites not bound to carbon monoxide actually hold onto their oxygen more tightly. They increase their affinity. This makes it harder for oxygen to be released to the tissues, worsening the hypoxia, even if the pulse oximeter reading looks okay initially.
So just giving 100% oxygen at normal pressure helps clear some carbon monoxide, but it doesn't immediately fix that affinity problem or the direct poisoning of the mitochondria, right?
Exactly. Hyperbaric oxygen therapy is a definitive treatment for a couple of reasons. First, it provides immediate massive tissue oxygenation directly through the dissolved oxygen in the plasma, totally bypassing that poisoned hemoglobin pathway. That buys time. Second, and crucially, the high pressure physically accelerates the dissociation, the kicking off of carbon monoxide from both hemoglobin and, critically important, from myoglobin in muscles and cytochrome C oxidase in the mitochondria. Reversing that mitochondrial blockade quickly is vital. Clinically, you need to track symptoms closely: loss of consciousness, neurological changes, heart issues like myocardial ischemia, metabolic acidosis, and be very aware of delayed neurological problems, which can be permanent if treatment isn't rapid. The protocol detail reflects the urgency, usually 2 to 3 atmospheres absolute pressure for 60 to 90 minutes, breathing 100% oxygen. This might be repeated depending on the patient's carboxyhemoglobin levels and how they're doing clinically.
Got it. Fast and aggressive. Next up, injuries caused by pressure changes themselves. Decompression sickness and arterial gas embolism.
Right. Decompression sickness, or the bends, happens from a rapid decrease in surrounding pressure. Classic examples are scuba divers ascending too quickly, aviators, sometimes deep tunnel workers. Nitrogen that dissolved into tissues under high pressure comes out of solution too fast and forms bubbles, emboli. The review notes this can even happen at high altitudes, over 5,500 meters. Arterial gas embolism is a bit different. It's often iatrogenic, meaning caused by a medical procedure. Air accidentally gets into the arterial system, maybe during central line placement, heart surgery, even hemodialysis.
And the consequences of these bubbles can be widespread and severe.
They really can.
Yeah.
It ranges from relatively mild things like skin rashes or joint pain to devastating neurological problems, paralysis, confusion, vision loss, problems with bladder or bowel control. And of course, bubbles can block critical blood vessels, which can be fatal. The standard treatment is immediate recompression therapy. You put the patient back under pressure, typically 250 to 300 kilopascals, for 2 to 5 hours. This physically shrinks the bubbles and forces the gas back into solution so the body can eliminate it safely. Aggressive hydration is also key.
Okay, let's talk about a different kind of tissue damage. Osteoradionecrosis. This involves using hyperbaric oxygen therapy, often before planned surgery in radiated areas.
Yes, osteoradionecrosis, or ORN, is essentially irreversible bone death. It most commonly affects the jawbone, the mandible, after radiation therapy for head and neck cancers. The underlying problem, the pathogenesis, is complex. Radiation damages the small blood vessels, leading to chronic hypoxia in the bone. It also reduces the number of healthy cells, hypocellularity, and messes up normal bone remodeling by suppressing osteoclasts. Clinically, you see exposed dead bone that persists for more than 3 months. And it doesn't happen right away. The onset is usually delayed, maybe 4 months to even 2 years after radiotherapy finishes. Symptoms can be severe intense pain, bad breath, halitosis, altered sensation dysesthesia, altered taste, dysgeusia.
And why is the timing of hyperbaric oxygen therapy so critical in this situation?
It's about preparing the tissue before the additional trauma of surgery. Hyperbaric oxygen therapy works here by reversing that radiation-induced hypoxia and stimulating cell regeneration and new blood vessel growth before the surgeon makes an incision. The protocol detail, often based on the well-known Mark's protocol, is specifically designed for prevention or pre-treatment. A common regimen is 30 preoperative sessions followed by 10 postoperative sessions, each lasting about 90 minutes. The key insight is that those 30 sessions before surgery are crucial to maximize angiogenesis and fibroblast activity. You're trying to ensure the surgical site has the best possible blood supply to heal before you even cut, because healing after surgery in heavily irradiated tissue is notoriously difficult.
That makes sense, preparing the battlefield. Okay, moving towards more restorative uses. F-wound healing, skin grafts, and flaps.
Right, this is where hyperbaric oxygen therapy is used for things like non-healing diabetic foot ulcers, certain burns, helping compromised skin grafts take, or improving the survival chances of surgical flaps. The common factor in all these is compromised tissue that's struggling to get enough oxygen nutrients from the host bed. The mechanism relies directly on what we've discussed: improving fibroblast function, boosting collagen synthesis, and promoting that critical neovascularization into tissues that are dependent on the host. The protocol detail here is pretty intensive. Typically 2.0 to 2.5 atmospheres absolute pressure for 90 to 120 minutes, often done twice a day. That rigorous schedule achieves about a 10-fold increase in the dissolved oxygen level in the plasma, really maximizing that diffusing gradient to drive healing where local blood flow has failed.
Tenfold increase, wow. Finally, let's touch on central nervous system applications like in stroke and trauma.
Yes, this is a really interesting and evolving area. Hyperbaric oxygen therapy seems to have a potentially valuable, though complex, role. In stroke and brain trauma, studies suggest it can induce angiogenesis and help recruit progenitor cells, both vital for neurological repair. Importantly, it also seems to reduce levels of inflammatory cytokines. This could be really significant in limiting the penumbra, that area of salvageable tissue around the core of a stroke that often dies off due to secondary inflammation. In other types of trauma, like muscle contusions, it might accelerate muscle fiber regeneration by suppressing that initial, sometimes excessive, macrophage infiltration, which can actually hinder healing. So, potential applications range quite widely, from acute issues like cerebral edema after trauma to chronic stroke recovery, targeting memory or speech loss, even things like post-anorexia encephalopathy or neuroblastoma stage 4. The mechanism here seems to go beyond just providing oxygen. It's influencing cell signaling and recruitment. Okay, let's pull that all together. Intersection mega recap. The clinical success of hyperbaric oxygen therapy across all these diverse applications ultimately rests on its unique physiological advantage. It elevates plasma oxygen concentration so high that it can overcome the diffusion barrier created by ischemia or damaged blood vessels. This high-pressure delivery system then enables specific downstream effects, killing anaerobic bacteria, promoting VEGF-driven blood vessel growth, reducing harmful inflammation, stimulating repair, making it a powerful tool, particularly for complex chronic and acute conditions where compromised vasculature is the underlying problem.
Okay, this brings us to a really critical part of the discussion: safety and risk. Anytime you're working with high-pressure environments and delivering 100% oxygen, clinicians absolutely have to understand the potential downsides, the risks involved. Let's start with the absolute no-goes, the contraindications, and major limitations.
Right. If we synthesize the information from the review, the top priority conditions are those that significantly increase the risk of either barotrauma injury due to pressure changes or oxygen toxicity. The main absolute contraindication is an untreated or inadequately managed pneumothorax, a collapsed lung. The risk of developing a tension pneumothorax where air gets trapped and pressure builds up dangerously during pressure changes in the chamber is just too high. It's acute and potentially fatal. Similarly, any condition with a very high inherent risk of lung collapse would likely preclude treatment.
Okay, so untreated pneumothorax is absolute. What about things that are more like limitations, requiring careful management rather than outright exclusion?
Conditions like a recent ear injury or recent chest surgery fall into this category. They make the patient much more susceptible to barotrauma. Also, importantly, active upper respiratory tract infections are a major limitation. Why? Because sinus congestion and eustachian tube dysfunction make it very difficult, sometimes impossible, for the patient to equalize pressure in their middle ears and sinuses. This dramatically increases the risk of painful ear or sinus barotrauma. Other limitations mentioned include uncontrolled hypothermia, core temperature needs to be stable, and significant claustrophobia. Being enclosed in the chamber can be very anxiety-provoking for some patients, affecting compliance. And the review clearly lists pregnancy as a strong relative contraindication. We just don't have enough data on fetal effects of hyperoxia and high pressure, so it's generally avoided unless the treatment is absolutely life-saving for the mother, like in severe carbon monoxide poisoning.
Okay, let's get specific about barotrauma. These seem to be the most common acute issues. We mentioned mild headache or fatigue, but the pressure injuries are more concerning.
Exactly. The barotrauma complications all stem from the failure of air-filled body cavities to equalize pressure with the chamber environment as pressure changes. Number one is otic barotrauma. This is the most frequent problem. It happens when the pressure difference builds up between the middle ear and the outside, usually because the eustachian tube isn't opening properly. This can cause severe ear pain, it can rupture the eardrum, tympanic membrane, and potentially lead to hearing loss. You can also get fluid buildup behind the eardrum, a serious effusion, which can also rupture things. Number two is sinus barotrauma or barosinusitis. Similar mechanism, but in the paranasal sinuses. Blockages, often from swelling due to infection, trap air. Pressure changes cause intense facial pain and sometimes nosebleeds, epistaxis. And number three is dental barotrauma, sometimes called barodontalgia or odontocrexis. This is tooth pain or even a tooth fracture caused by trapped air expanding within defective fillings under crowns or in undetected cavities during pressure changes.
Ouch. Okay, beyond the purely mechanical pressure injuries, there's the physiological risk of the oxygen itself. Oxygen toxicity. This affects the central nervous system and the lungs. This must be a primary concern, especially with the higher pressure protocols.
It absolutely is. Oxygen toxicity and central nervous system complications are often linked to what's called the Paul-Bert effect. Essentially, high oxygen levels generate reactive oxygen species in the brain tissue faster than the local antioxidant defenses can handle them. This can manifest as changes in brain electrical activity, but potentially leading to generalized seizures. That's the most dramatic CNS effect. Patients might also experience temporary vision changes, most commonly transient myopia or nearsightedness.
And what about the lungs? How does high oxygen affect them over time?
The pulmonary complications are more related to prolonged exposure to high partial pressures of oxygen, sometimes called the Lorraine-Smith effect. This can cause inflammation and damage to the lung tissue itself. In severe cases, it could lead to things like subcutaneous emphysema, air under the skin, intrapulmonary hemorrhage, bleeding in the lungs, or pulmonary edema, fluid accumulation. This is precisely why strict adherence to treatment duration and pressure limits is so crucial.
So how do you prevent acute oxygen poisoning, especially during longer treatment sessions? Are there specific protocol adjustments?
Yes, the main strategy involves breaking up the oxygen exposure. Prevention relies on giving the patient short, scheduled breaks during the session where they breathe normal air. These are often called air breaks. This cyclical approach allows the tissues, particularly the brain and lungs, to temporarily clear the excess oxygen load, reducing the risk of toxicity building up. And beyond that, every single treatment needs to be carefully dosed, considering the patient's age, their specific condition, the location being treated to minimize the chance of exceeding that toxic threshold.
Okay, risk management is critical. Now, let's pivot from dealing with risk during treatment to using hyperbaric oxygen therapy proactively. Hyperbaric oxygen preconditioning, or HBOPC. This sounds like a really exciting preventative strategy.
It really is.
Yeah.
HBOPC is defined as using a specific, often lower dose exposure to hyperbaric oxygen therapy before you anticipate some kind of ischemic or traumatic insult is going to happen. It's shown some really powerful protective effects in scenarios like diving, where it seems to reduce bubble formation afterwards, and also in protecting against planned or potential ischemic events or inflammatory conditions.
What's the actual molecular mechanism behind that? How does a prior brief exposure grant this protection?
This comes back to that signaling paradox we discussed earlier, but in a planned way. HBOPC seems to work by priming the body's own defense systems. It activates endogenous antioxidative enzymes, particularly within the central nervous system. The review specifically highlights key enzymes like catalase, superoxide dismutase, and perhaps most importantly, heme oxygenase 1. By upregulating these protective enzymes before the damage occurs, whether that's a stroke, a traumatic injury, or reperfusion, the tissue is essentially biochemically prepared, more resilient.
And what kind of protective effects have actually been demonstrated?
The effects are quite impressive. HBOPC has shown potent protective effects on both the brain and the heart. It demonstrably protects against focal cerebral ischemia, like in stroke models and traumatic brain injury. Furthermore, studies show it can effectively reduce brain edema, minimize harmful microglia activation, and lessen inflammation following events like intracerebral hemorrhage. It's essentially turning the patient's own biology into a shield against anticipated harm.
Very interesting potential. Okay, let's solidify this section with a clinical dilemma that forces prioritizing different types of risk. All right, here's a board-style question. An older patient presents following a stroke. They're considered an excellent candidate for a course of chronic hyperbaric oxygen therapy aimed at improving residual speech and memory problems. However, their history includes chronic obstructive pulmonary disease, or CRPD, with known residual air trapping shown on previous tests. They also report mild to moderate claustrophobia. Which of these factors presents the greatest absolute safety hurdle that requires immediate aggressive management before you'd even consider starting hyperbaric oxygen therapy?
Okay, tough clinical decision. You have to prioritize the risk that could lead to acute life-threatening harm over factors that cause discomfort or require management. While claustrophobia is a real issue for chamber tolerance, a limitation, and COPD itself is a risk factor, the key piece of information here is the residual air trapping. That specific feature of their COPD significantly increases the risk of pulmonary barotrauma, especially developing a pneumothorax during decompression from the chamber pressure. That represents the greatest absolute safety hurdle. So before starting hyperbaric oxygen therapy, this patient would need rigorous pulmonary assessment, maybe high-resolution CT imaging, and potentially specific management strategies focused on that air trapping risk. You have to address the highest acuity risk first. It requires synthesizing the contraindications with the specific physiological risks. #tag 6, outro and final takeaways. So if we were to synthesize this entire deep dive down to its core, the fundamental mechanism of hyperbaric oxygen therapy is really a shift in gas physics. It uses high pressure to exponentially increase the partial pressure of oxygen dissolved in the plasma.
And it's that pressure-induced solubility, that steep diffusion gradient, that allows oxygen to be driven deep into compromised ischemic tissues, places where normal capacity-limited hemoglobin transport has already failed.
Right, we established that quantitative foundation. And we track the consequences, how it fights infections by stimulating immunity and directly killing anaerobes, how it promotes wound healing via vascular endothelial growth factor and neovascularization, and its critical role in neurological protection, recruiting cells and activating those endogenous antioxidant enzymes.
Absolutely. However, the source material we reviewed is also quite clear about the future direction for the clinical community. Despite all these demonstrated successes and plausible mechanisms, there's still a clear, an urgent need for more large-scale, long-term, randomized controlled trials. We need those studies to definitively assess the long-term outcomes, the true frequency and severity of complications, and, really importantly, the cost-effectiveness of hyperbaric oxygen therapy across its many different applications. That level of evidence is still needed before it can achieve universal acceptance for all potential indications.
A call for more robust data. Okay, we'll leave you, our listener, with a final provocative thought to consider for your own practice. We talked about hyperbaric oxygen preconditioning and its potent effects stimulating those endogenous antioxidant pathways like heme oxygenase 1. So the question is, how might we justify and, perhaps more importantly, leverage this preconditioning concept? Could we move beyond its current use in emergencies like ischemia or diving and apply it to manage highly elective, non-emergency surgeries in patients we know are at high risk? The potential to intrinsically boost tissue resilience before a planned surgical insult seems like it could hold immense promise for improving outcomes and reducing complications down the line, something to think about. And that concludes this week's deep dive. We certainly trust this comprehensive synthesis provides the kind of high-fidelity detail that's useful for your clinical practice.